not intended to malign any religion, ethnic group, club, organization, company, municipality, individual, or anyone or anything.
He's a surgeon. He's a 100-ton boat captain. He's a lieutenant on Seaside Heights Beach Patrol in New Jersey. He's a member of the Coast Guard Auxiliary. He's Dr. Michael Kachmar. Need answers to your medical questions? We have them. Listen in to hear latest on medical topics related to all that and more.
Hello, everyone. This is Dr. Michael Kachmar. How's everyone doing today? This is today's date is March 22nd, the year of our Lord, 2025 AD. I'm Dr. Michael Kachmar. I'm a board-certified reconstructive foot and ankle surgeon, practicing about 40 years now. This is our show. We're on all the platforms, Spotify, as well as we do a podcast. And so we do medicine,
politics,
we have
mixed bag of stuff, you know, whatever Dr. Kachmar feels like chatting about, we chat.
So Jeremy, this is Jeremy, my sidekick.
Guys.
Can you post up?
Doing?
Can you put up on our screen our contact information?
Sure.
So we're going to do a show today talking about bunion surgery. It seems actually becoming controversial now. So if you want to get a hold of us, there's a lot of ways. One is you can make an appointment in the office or call 732-269-1133. That's 732-269-1133. You go to my webpage. It's JerseyShoreFootandLegCenter.com. That's JerseyShoreFootandLegCenter.com. And if you want to call in today and talk to us, number here is 732-237-4949. That's 732-237-4949. We'll accept calls in about a little bit, about halfway into the show. Anyway, so again, my credentials: I'm on staff at 4 hospitals. I'm a board-certified reconstructive foot and ankle surgery, and I've been doing surgery about 40 years. I've done 10, 20,000 procedures, probably more. You know, and anyway, that's my credentials. So we're going to talk about bunions. I've been watching this stuff on the internet now, and especially Facebook. All these procedures, you know, people are advertising bunion surgery and what kind of bunion surgery and what should I have, and minimal incision or these 3D and all this stuff. So let's just talk about bunion surgery and what it is. So let's go to my video, my screen. So let's just get a definition of bunions. Okay, so the word bunion, B-U-N-I-O-N-S. The medical term we use is hallux valgus, H-A-L-L-U-X, and then valgus.
How often do you use that?
V-A-L. Well, that's what we use. That's V-A-L-G-U-S. So that's something. So bunions happen when something puts extra pressure on the big toe. I don't really agree with this. I think this is at a Mayo Clinic. So what is a bunion? What does it look like? And if you look at the picture here, we're going to zoom it out here.
See it.
So if you could see on the, the bone is crooked. And that's called the metatarsal phalangeal joint. People who are on the podcast, you got to go to our
You know what I see all the time on the TV? I see them putting like a brace on that, and then they twist it, and then the toe straightens out. And do braces like that? Do they train the foot to lose that bunion, don't you believe in them?
No, it's not what I believe. I've never seen that work, but you want to try it, try it. People, there's always going to be somebody say, that helped, So let's go here. Types of bunions, and this is really important because when you talk about bunion surgery, it really has a lot to do with what type of bunion, what kind of bunion, how old you are. It's a lot. So you got congenital bunions, basically. I'll say some babies are born, but I see juvenile. So you have juvenile bunions. I don't think I've ever seen a baby born on bunions, but juvenile, very young. Taylor's bunion is a bunionette. That's on the other side of the foot, the little toe, and it's very common. And you could have symptoms: pain, swelling, stiffness. Pain is the big thing, and difficulty wearing shoes, Or what happens too is the bunion gets bad enough, you get hammer toes, and that goes with the bunion, and then you can't wear shoes, and the shoes rub on the foot, and you get these sores and pain.
Right.
So that's what's going on. You got hammer toes, callous skin. And we just go on and on. So, again, what causes it? I tell you one thing that aggravates it is high-heel shoes. No doubt about it.
Really?
Definitely high-heel shoes. So if you got, and shoes in general that are too tight. So if you have a bunion, the first thing you should do is get a wider shoe, get out of the heels, get a wider toe box.
Right.
And a lot of times that helps. We call that shoe modification.
Shoe modification.
Now, here's another thing. Risk factors. Females definitely get bunions more than males. I think.
Have you seen their shoes? Every shoe, right down by the toes, it squishes them in, and they look they look weird.
Yeah.
You know.
I think that a lot of you see guys who wear cowboy boots a lot, they get bunions. So
they really,
yeah, and it goes here complications. Again, you could go on the internet. This was at a Cleveland clinic. I got to give them. They have really good stuff here. Management. So what do you do? How do you treat bunions? So, and again, this is a generalized overview. Footwear changes. We call it shoe modification. A lot of times that takes care of it. Just get a bigger shoe. Just because you have a bunion doesn't mean you have to have it operated on.
Right.
We could give cortisone injections. You could wear, the things at night if you want, but basically get a wider pair of shoes. Stop pushing on it.
Actually, I wear my shoes. I get wides and I was actually talking to my son about it because he's got like an extra bone on the inside.
Yeah. Orthotics help.
Yeah, he's using the orthotics, but I also told him. I said, son, you can buy those same shoes, but just get wider ones, and it probably won't bother you as much.
Yeah. Well, no, shoe gear is a big thing, and the wider the better, and lower heel. Get the heel down. Yeah. But that really makes a big difference for a lot of people. And again, you don't have to have it operated, but orthotics, injections, anti-inflammatories, wider shoes. Bunion pads, over-the-counter taping, and like you said, those braces. If you want to try them.
No, what about like you see these ballerinas and their toes are down? Do they suffer later in years?
Yeah. Well,
They
get really bad feet.
Yeah, they must.
Yeah. So pain relievers, anti-inflammatories, icing. Steroid injections. We give it steroid injections, physical therapy, and then ultimately surgery, bunion corrective surgery, which we're going to focus on today. Okay. And so do they go away on their own? Can you prevent bunions? That's a good point. There is some studies, and I've seen these over the years that if you stay away from the pointy shoes with a high heel, there is some evidence to show that worsens them, accelerates them. I don't know if it causes it, but it definitely puts the strain on
it.
The
fashion is not worth the risk.
Right. So and
you're going to give yourself a lot of grief later on.
So it says, what can I expect with bunions? Well, I've done a lot of surgeries. We'll talk about that. And I'm just keep going down here, and I think that's it. So why don't you go back to me, Jeremy?
You figure like these women are, they go dancing, going down to Jenkinson's at the boardwalk, and they go dancing in the clubs and stuff, and in these high-heeled shoes with the pointy whatever. I mean, you're just doing damage, jumping up and down and shaking your stuff.
Yeah, but we see a lot of juvenile kids, never dance. They don't wear high-heel shoes. We get kids that come in the office 12, 13, 14 years old with bunions. So that's not just the answer. There's more to it than shoe gear. I think the shoe gear aggravates it. Yeah. I think it's a predisposition. Seems that women have it more than men, but I've been in countries where people don't wear high-heel shoes, don't wear shoes, and they have bunions. Okay, so you can't just say it's the shoes, and I don't think the literature substantiates that. It's a congenital thing, abnormality. It seems to be more women than men, but we've seen enough, men, and there's different types of bunions. It's when we get into this bunion, it's a generic terminology. And like a good example, somebody comes in to me and they say I have a bunion, and they had surgery before. Well, that bunion, that joint is shot. There's things going on there that are a little bit more involved. Anyway, so let's just talk about, so let's just say you think you have a bunion, you want to come and see me. So I'm going to give you some things here. I'm going to give you a procedure that I've done for 40 years. And we call it the Austin bunionectomy, okay? There's a ton of literature. We're going to pull it up on my computer here. I've done thousands and thousands and thousands of these. Now, I'm not saying this is the only procedure that's done. See, that's another thing. There's a lot of different procedures that can be done for bunions. It depends on several factors.
Right.
One is what type of bunion you have, and there's different angles we look at, foot type, all of that. Right. Also, your age. You may not do one procedure, even if it's the same type of bunion. You may not do the same thing in a 90-year-old as you're going to do in a 20-year-old.
Right.
is, it depends on how good your circulation is. If you're a diabetic, is there comorbidity? Do you have a family history of blood clots? All of these things are risky. So, you have to modify sometimes a surgery based on other things than purely whether or not this procedure is going to be the best for you, purely from what you're presenting with the angles and deformity. So I'm going to give you a whole bunch of procedures that I've done over the years, and I've done everyone that's every one that you could think of. So the Austin procedure, and it's called and modified Austin. The other word for this is chevron. This is a paper. I don't know if this was out of the American Journal of Foot and Ankle, but let's go to the video, as they say. So this, the author here was Vincent J. Harrington. So it's called Austin Procedure and Modified Austin Procedure. The word, let's forget the spelling. It's Austin. Okay, and it's been around for many. Ooh,
you read this?
Oh, well, yeah. So listen, the procedure was presented initially by Dr. Dale Austin in his 1981 publication. Now, I started operating in the late 80s, so, I've done tons of these. And basically, I'm not going to read this whole report, but here's a picture of what we do.
Oh, yeah.
Okay, you see it right here? And people got to go. So that line there is where you cut the bone, and you top one there, you can move it over. And it corrects the angle. See that, Jeremy? See? And that's a traditional, there's modifications to this, and that's what this paper talks about. And when we talk about bunion correction, the big thing is every deformity is in 3 planes. I don't want to get involved too crazy, but, so you got up, down, sideways, and front and back. Yeah. So these new procedures today, they say, well, we correct it in 3D, well, the problem with a lot of these bunions is that they're predominantly one plane, so you don't have to correct every, plane of deformity. That's my opinion, But I've done thousands of these, and they've done very well, And here it is right here. Here's, you can see the bunion, right?
Oh yeah.
See how the bone goes out.
No, that's a really exaggerated version.
No, it's that bad. They're that bad.
They're that bad.
They're that bad.
Wow,
Yeah. That's not exaggerated. Here's some, cuts in the bone. And this is what we do here. And again, some people could look at this. This is a little bit graphic. And
go back to this other picture. Now, I just want to have a look at it.
Yeah, you're cutting the bone with a saw. We do that all the time. It's a saw. That's why you got to, and it's a pretty straightforward procedure. But if you look here, see this one here? That's a pin, one little pin like that.
Right.
And I've done again thousands of these, and I'm not bullshitting. And I've had great success. I have people come to my office 30 years later. I'm still, and they do great. They come in for something else. Okay, so and there's ways to to fixate it.
Oh wait, go back up a second. I want to see this. Okay.
So you got a little bit of that's a staple in there. So these are all. People should go onto our webpage. Onto the YouTube channel. So this is the traditional. I love this one, and here it is right here. There it is. Before, up top, after the procedure, and pretty straight. It corrects it, and it's minimal risk. Pretty quick turnaround time. Here it is right here. See, and you got to be careful how you do it, but you straighten up the toe. These are some complications here.
Whoa. Let me see those. Wait.
No, we don't want to show that. All right, let's go this way. So let's go. Go back to me. Go back to me.
Okay. All right.
Nah, you don't want to gross people out. But listen, any procedure has complications, and that's something. So that's the Austin bunionectomy. I've done, like I said, thousands of them. They work real well. They started in the 80s. So you've got how many years of literature? 89, 30, 40 years of literature, and it's pretty good. There's a lot of, what do you call it? History out there, and thousands and thousands of procedures, and people are very, very happy. Now, when you do a procedure, you pick the Austin. You got to be. It's not for everybody. It's not for every bunion. All right, there's a criteria that you follow, and that criteria is very complicated, and that's why we train and we learn, what criteria would be indicated to do an Austin bunionectomy, and it's also the person that you're dealing with, do they got good bone stock? Do they have any other comorbidities? Is there right. So it's very complicated. That's why if anybody says, "Oh, this is the one procedure that's for everybody," and this is it. That's no.
No, there's no such thing.
No, not in my opinion.
Yeah.
And I see doctors. I go to seminars. Oh, this is it. This is the one. I've been hearing that for 30 years. This is the one. This is the best one.
We were just talking about this on Dr. Jasper's show. All these patients coming in thinking it's one and done. One and done. That's all I want is one and
Let me tell you something. Anybody out there, I'll tell you this. Whatever doctor's going to operate on you, ask them, right? Look at them and say, guarantee me that I put it in writing that I will be 100%, no problems, no chance of complication, and my foot will be like it was when I was 20 years old. They won't do it.
Won't do it.
Any procedure has risks, potential complications.
If you got to cut in, there's a risk. That's it.
Right. And I'm not saying don't have bunion surgery. I mean, but I get people come in and they want to have it because it's a cosmetic issue. I said, no, if you don't have pain. But my point is that, I try to do, here's what I try to do when I do surgery. I try to do on any kind of surgery. I'm like a stealth bomber. Like I want to come in, I want to blow up the munitions factory. But next door is a school. Okay? I want to come in, drop my bombs on that munition and not touch the school.
Right.
Okay? You don't want to have collateral damage. Same thing with bunion surgery or any surgery. You want to get in, you want to do the quickest, easiest, less risky, best bang for your buck, right? Some of the procedures out there today are ridiculous. I mean, they're dropping a bomb and, you got to be careful. I always used to say this.
Get out.
Well, listen. Let's just say we talk about percentages. This is kind of the way I think. Maybe this will help you to understand. Mm-hmm. You come in with a bunion, and I could say, I could correct it to about 90% of what you had. Follow me. This again, say 90%.
90% is great,
and you probably won't have any pain. You'll probably do well. Maybe the bunion will drift back a little bit, but with maybe 2%, 5% risk. Very minimal risk. Probably maybe less than 1% risk. Okay? Now, but I could correct it 100%.
Right.
But the risk goes up 20%.
Right. I gotcha.
That's what I see happening today. And I'm like, wait a minute, okay, So I mean, if you want to, so it's all dice throw. So you better, here's another thing. You should be having a surgeon who operates on you who's board certified.
Board certified.
Not board certified, not only in foot surgery, but reconstructive foot and ankle surgery. Like I am, like other doctors, not everybody out there. And it's amazing to me when people come to me and they had these doctors and they're not board certified. I'm like, now some of them, I'll give them credit. They got out of school. They've been out for not even 5 years, and they got tremendous credentials, and they're board qualified, not certified. They're probably good. They came out. But if you got a guy who's 30 years out, 20 years out, 10 years out, and he's not board certified, I don't know if he could handle some of this stuff.
Yeah,
or she.
So
you understand what I'm saying?
No, I do. So the difference between board certified and board qualified. So qualified means that you're able to be certified, but you haven't been.
Yes.
Yeah.
Yes. So what happens is the way
that really means nothing at all.
No, it does. Does
it?
Yeah. Because here's the thing: you do your residency. Now every specialty is different. This is in foot and ankle surgery.
Right.
You do a residency. Could be 3 years, 3-year residency. Okay. Now you do all kinds of procedures in the residency. After the residency, before you go out and practice, you take your boards. And you take your board, so you become board eligible. Okay, not board qualified. So if you don't pass those boards, you're not board eligible. I would not even stay away from that person.
You have to pass the boards to be qualified.
Yes, but you could still practice medicine and still go out there and operate. But I don't know if every hospital will give you privileges. But so that's the first step. So that means that that means that they tested you to see your proficiency, what you learned in your residency.
Right.
And that's where you should be. So now you come out of your residency and you did 3 years, you're board qualified in foot surgery and then also foot and ankle and rear foot surgery. Okay. I would say that person is good. Now you got 5 years to get board certified. So now those are good surgeons. I'm very sure they'd be very, very good. I would talk to them. That's solid. And then the next level would be you get somebody, a guy or girl who's out 10, 15 years. They should be board certified at that point. If not, I would run the other way.
Right.
Or ask them why, So, I mean, I had a doctor who I was
certified rather than qualified.
Well, I had a doctor who was neither board certified nor board qualified, asking for privileges at one of the hospitals I worked at, and he told me that he couldn't get board certified because he's a poor test taker. So, I mean, I just want to tell you.
Yeah.
All right, so let's go back to the video.
There's some guys like that.
Okay.
Yeah.
So now the next procedure that I've done, thousands of them, is called a closing base wedge osteotomy. Okay?
Yeah.
So for people, so it's closing, which means CLOSING, base wedge osteotomy. This is a very, very good procedure, very powerful. This is for maybe a more worse bunion, and I've done tons of these. A lot of them I do these on children over the years. There was a couple papers written with regard to how good this procedure is. Again, technically difficult. You got to know what you're doing, and there's different ways to do it. But pretty much what you do is, here's your bunion. So here's the picture. See it?
Yeah.
And let's see what you do over here. And here it is. Here you make the incision, and let me just show you. So that's probably not the best. So here it is right here. And there's different ways to fixate it. They put screws. I just put one pin and take it out. But this is you make the cut at the base. Let me see if they show you. So you're making a cut at the base of the bone. There's some screws there. I'm just trying to see. So this is at the base of the bone. I didn't show a picture of it. I'm sorry. So this is a closing base wedge, and it's done right at the base of the bone here. So you know what, Jeremy? I'm sorry, but you can see where the hardware is. I didn't show it here.
Yeah, I see it though. I mean, I know what you're talking about.
Yeah, so it's done. So right here, see where the screws are? So right there is where the cut was in the bone. See right there? Yeah. And that's called a closing base wedge. And that's a very powerful procedure. It's very good. I've done right there. Up a little bit more. Right there. That's where the cut is. You can't see it because the screws are, that below is the joint. So it's a very, very good procedure. And again, it's been around for many, many, many years.
As the patient, are you when you reach down and you're you're rubbing your feet and all that? Do you feel those pins when they're in there, or
well,
not really?
The more hardware I take all my hardware out. First of all, when I do a closing base wedge, there's one pin, 5/60, and that comes out. So here, listen.
So it doesn't stay in. It just goes.
Not mine,
it's
but
there,
some people, right? Some people put a ton of hardware in there, and it can become very painful. But let me closing base wedge osteotomy. This is according to these doctors here. This was a paper done by these doctors. Closing base wedge osteotomy is an effective procedure that requires adequate preparation and surgical skill to create successful and reproducible results. The osteotomy allows for greater reduction of moderate to severe intrametatarsal angles in rigid first ray that are not possible with distal metatarsal procedures. Utilizing hinge concept, complication, blah, blah, blah. So anyway, when was this paper done? Let me see here. So, but this has been around for many, many years. We were doing these in the 80s. I'm trying to see when this paper came out. I'm just trying to give you 2017. Not that long ago. All right, you could go back to me.
Sure thing. So
now you have the Austin bunionectomy and your closing base wedge. Okay, you got those so far?
Yeah.
Now, I'm going to give you the next one that's the mainstay procedure, okay? And this is a fusion of the first metatarsal joint. So let's go back to the picture here. So this is, called first metatarsal phalangeal joint fusion, an excellent outcome. This was done in November 2022, okay? Journal of Orthopedics, Foot and Ankle. So here it is right here. Can you see? You fuse that joint. Yeah. That's where the bunion is. Now, if that fuses, that's it. The joint don't move anymore. So that's the downside to it. But it gets rid of the pain and gets rid of the bunion. You see? So that's another good procedure to do. All right?
What's that? What's this, though? This ball?
These are normal. They're sesamoid bones that are in there. They're sesamoid. So, and the fusion is done. I've done many of these over the years. And, here's a good, now this is not necessarily a bunion. This is an arthritic joint. See the joint, how it's all chewed up and everything? See it? These are probably, maybe they had surgery done and it failed. Maybe there was trauma, It's hard to know. You go in there and you fuse it. Sometimes you put a plate, some screws, but it's a good procedure.
Now, is this just preference from the doctor, whether
No,
it's a plate or
no.
a screw or a
Oh,
pin?
yes.
So you put one pin in, that's your preference, and
Well, you look at the literature, like right here, there's cross screws, right now it depends, you look at the science, you look at what the papers say and what seems to do really well. Again, it's also the patients. If you have a patient who has osteoporotic bone, the bone is not healthy, I would what do you call it? I would maybe use different kind of fixation. All right. We used to, back in the day, we used to put 2 pins right down the foot and take them out. Right. Screws are okay. Plates are better. Maybe again, I don't want to dwell on. I tell you, fixation is important. You don't want to have too much fixation. These screws could back out. They could become painful. You want to get the job done. So some people, they want to walk them early. They may put a plate in there that's more secure. There's a lot of things. I think it's a little bit beyond the scope right now of us talking about it. But you got to be careful because too much hardware is no good.
Yeah.
Okay. And okay. So anyway, that is where we're at right now. So now you had the Austin bunionectomy, very common, and been for 30 years. Closing base wedge, been around for a long time. First metatarsal phalangeal joint fusion. Okay, there's one. Now let's look at this one. This is the newer procedure now. Well, let's go back to me. So the Lapidus procedure has been around for a long time. Now they're advertising this in Facebook and all over the place. And it's they're saying it's a 3D correction. But so it's called.
They kind of toss that 3D out there, like it's like ooh, it's.
Well, every deformity is in multiple planes. But listen. The Lapidus procedure has been around for a long time. There was a paper that I remember my colleagues that that they wrote. It was in the Journal of Foot and Ankle Surgery in 1996. Talked about it, and basically what you do here is you fuse the joint. So see where the hardware is. So see that joint. So it fuses. That's a fusion, and that's only a little bit of hardware. Usually there's 7, 8, 9 screws and 2 plates. So
now before your toe gets this way.
Right.
I mean, doesn't the patient realize that oh boy, what's going on here?
Yeah, but it doesn't hurt.
If they came to you sooner, would it be easier for you to treat?
Yes, but a lot of times they come to you sooner and they have no pain. It's hard to justify. We don't have a crystal ball, so I don't know if it's going to get this bad. It's a good point, though.
Yeah.
It's a good point. You operate on somebody who has no pain, and then they have pain after the surgery.
Right. Keep an eye on your feet, how they look. Feel your feet, touch your feet. So, and because you don't know, and the earlier you get in, the easier it's going to be for you.
Right. So this procedure here has been around for a long time. Yeah. But again, this procedure,
'cause that's mental.
Right.
That with the green arrow in there. I mean, that's
right.
Crazy.
But don't worry about how bad the deformity is. We see tons of it. But the big thing here is the procedure. This is one that now is being pushed big time by a lot of doctors, and it's indicated in certain people, but not everybody. That's my opinion. I mean, again, what do I base that on? 40 years of experience. And I've seen patients that do well with other procedures. Now, a very, very bad bunion like this, and if it's has a ligament laxity, this may be the best procedure. So what I'm trying to say is that
will they shave some of that bone down?
No, it just moves over a little bit.
I'm looking at it and I'm comparing the 2 bones. And
they sit a little bit. Yeah, they did, but it's moving over. The real surgery here is at the base, where the deformity is. It's the base. Right. So anyway.
But that's all. I mean, shaving all that.
Yeah, you go back to me.
That's part of the.
You go back.
Yeah.
When you go in, I'm being very curse here. When you go in, you make an incision, you loosen up ligaments. You sometimes you move ligaments around. Right. You have to displace the sesamoids. There's a whole thing.
This is the whole part of the reconstructive.
Right. I'm just giving you.
Part.
You have to. Cut the bone, move it in position. So I'm just giving you a very generalized, low key, an overview.
Idea, overview,
right.
Yeah.
But I want to make a point that what I'm seeing is I first of all I have people come to my office who, over the years, who have complications from every one of those bunions I just showed you, procedures. They've had non-unions, they've had chronic pain, the procedure failed, they had infections. Okay, so, and then we didn't even get into implants for bunions. But these are the major procedures. And what I'm trying to explain to you right now is that the procedure that you have done, there's no one procedure that's the magic bullet. There isn't. And it depends on the patient, where you are, how healthy you are, what your lifestyle is, number one. Number two is what type of deformity bunion you have. Is there arthritis? Is it just the angle? How bad is it? Is it excessive? Is there a lot of twist in the toe? I've had people come in where they have a bunion and their big toe is turned. It's turned, so there's a rotational component. So all of those things have to be taken consideration. Well, when I see somebody comes into me who has a mild bunion, right, and they want to do one of these aggressive procedures, I step back. I think ultimately what the doctor should do and the patient should ask for is give me all of the options and the pros and cons of each one. I don't tell a patient necessarily what procedure has to be done.
This is the only thing you're getting. That's it.
No, if somebody said, no, I'll say, listen, here's your options. Here's the, I could do this procedure. You get back this quick. Here's the complication. When the fusions, either of those two fusions, the one in the big toe or down, you could have a non-union. They could maybe not fuse. Sometimes they fuse in a bad position. So and I don't care how good of a surgeon you are. And some people walk on these excessively, or they don't heal up well. But so you have to really pick the patient, pick the procedure. So what I would do, so if you're getting these things, give us a call. Call us, and give me my phone number again for my office. You want a second opinion, a third opinion? I would recommend you come and see us. My number is 732-269-1133. We live in New Jersey. If you're somewhere else, go get another opinion. Before you have bunion procedure, go get multiple opinions. The insurance will cover it. Yeah. Don't be lazy, and ask these questions because, I've had people come in my office who are crippled. They're surgical cripples because they had the wrong procedure done. It was a, doctor who in my opinion, wasn't qualified to do it. Right. Okay? So, shop around a little bit. Find out who's doing them, how many they're doing them, and what their outcomes are. And they should have patients who have, you could say, I used to say, here, I got 5 patients who had the surgery done, and go talk to them. Ask them what the story is, Yeah. Especially like for me, I in Bayville and Tom's River, everybody, you get a reputation, so we had a very good reputation for years.
Oh, sure.
And, but I see this now because it's on the internet and it's all over the place. And I go to these seminars and every doctor, all these young kids, all these young doctors, they're doing this one procedure. It's the greatest thing since sliced bread. And I'm sitting there going, I raise my hand. I go, whoa. We have other stuff too, It's like, how about, that's a good procedure. Don't get me wrong. Right, and it's indicated, but it's not the end all.
Be all, end all.
No, it's not. Yeah. There's other procedures that may be a lot easier to perform, maybe a lot less risky, and maybe better for the patient in the long run. Right. But again,
it's not always the new,
Right. Yeah. I always think that these patients allow us to operate on them. It's a huge, I don't want to say privilege, but yeah, you're letting me, you're trusting us, and you want to have a conversation with the patient, and the patients who are listening to me want to have a conversation with the doctor, and ask them, are there other alternatives? What's the risk in this procedure opposed to another procedure, like an Austin bunionectomy? And why can't I have an Austin bunionectomy? They're going to say, well, it's a 3-plane, blah, 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 blah. I'm not so sure that I would agree with that. I would say, because there's 30 years of literature out there. Don't believe me. Go look at the literature. All of a sudden now, for 30 years, those Austin bunionectomy was decided or came out, in the 80s? So what about 90s and 2000, 2010? So all of a sudden now, all those hundreds of thousands, maybe I don't know how many people had the procedure done and have great outcomes, all of a sudden that's not appropriate anymore, or that's not, they just disappear off the face of the earth. Now this is the only procedure that, is going to do it.
The new one's shiny.
Closing base wedge osteotomy. I've done tons of them, and I got people coming back. I mean, they're beautiful. And I think the New England Journal of Medicine did a thing about closing base wedges. What a great procedure. Again, it's not for everybody, but it's for certain, and it could be, I do it, and you get it. I had it down where I put one pin in, pin sticking out for 6 weeks, and I take it out, and you got no hardware left. My other bunion, Austin, I put one little pin, and that comes out. It doesn't stick out, but you could leave it in, or you could take it out in 6 months. Do it in the office, real quick procedure. You make a little incision. You got no hardware, no nothing, and people do great with those. And I got people back to running. Athletes. I did a lot of closing base wedging in young kids. 17, 18. When I say it's a juvenile, once their growth plates are closed, I see them back. For other things, they're adult. I see their kids now. And my point is they do well. So I could tell you that. And also the literature backs it up. So don't get mesmerized by this, we're going to, 3D, this, that. Yeah, I mean, if you need that, then that's the procedure you want to get. And you want to get a doctor who is trained in that and does it, But you also got to understand that there's other procedures. Like some bunions are so bad and the patient's not a good candidate, they're older, maybe the fusion is the best thing. And there's other procedures I didn't even get into. Again, you have to be really careful and pick the right patient, pick the right procedure.
The right patient.
So in other words, the procedure has to match the deformity, but also the patient.
Right.
And there is not one procedure, in my opinion, that fits everything.
Right.
There's no one procedure that fits every patient and every deformity. And if you tell me that's the one, I'll argue from now until doomsday, because my experience does not bear that out. You follow what I'm saying?
Yeah.
So, and that's it. So I mean,
that's the whole point of finding a board certified, foot and ankle reconstructive surgeon like you. You want the best. You want the guy who's going to go in and not be surprised by what he sees, because he knows how to take care of it.
Right. Yeah. And the United States, let me make a point too, because there's two groups of doctors that are really good at bunion surgery.
Right.
So let me give you so I'm a doctor of podiatric medicine, DPM. So my credentials, and I'm board certified in foot surgery and reconstructive rear foot and ankle. You follow me?
Yeah.
Okay. The other group of doctors who I would go to if you're a patient is a fellowship, listen to me, an orthopedic surgeon, but not just any orthopedic surgeon, an orthopedic surgeon who is fellowship trained in foot and ankle surgery.
Right.
You see what I'm saying?
Mm-hmm.
So they got to be specially trained. Now those two groups of doctors right there are highly qualified, specialized into this surgery. And that's where I would go. Is one better than the other? I don't think so. But, some people argue one way or the other. I don't know. You could say yes, no. To me, that's where I would focus. And then I would get my opinions. And I think that at least, if you go to one, you got the one opinion, he's going to say, listen, you got to have this procedure done. And then you go to another doctor and he says, no, I wouldn't do that. Then you go to another, again, and then go on the internet, read. Don't just read testimonials. I had Dr. Goomba operate on me. Go look at the papers. You could pull up the papers. They're not that hard to understand. Look at the literature and talks about the outcomes. There's a couple papers you could go look at. They looked at 3,000 people, and here's the outcomes. So I think that what I would look at from a patient standpoint is what procedure is the less risky. Don't have too much hardware, not too long in the operating room. Quickest recovery, but the least amount of complications.
Right.
With the best correction and longevity. Think about it too. Is if you're 20 years old, you want that bunion not to come back. You want to get a good procedure. But the other side of the coin is, if you're 85 years old and you can't wear shoes, you want a quick fix. Some people come in who have like hammer toes and they're 85 years old. We recommend just amputating it, because the surgery, just get rid of it. It's done, because you're back in a couple weeks, maybe 3 weeks, as opposed to correcting it, putting screws in there. You got anesthesia. There's a lot of things going on. You got heart problems. You have to understand that surgery could really cascade into a nightmare.
Yeah.
So an amputation is quick, and we do. I haven't been operating for about, because my shoulder, I had shoulder surgery, so I haven't been operating at all for almost a year now because I do stuff in the office, but I can't because I had 4 surgeries on my shoulders. Talk about surgery, so I'm getting there. But my point is that so I've been sending stuff out to my colleague, Dr. Kennelly, and he does the amputations in the office. But a lot of people benefit from that. So there are, again, that we wouldn't do that on a 20, 30-year-old, but you would do that on somebody who's older. And
give me an age range.
Well, let's just say you're 85 years old, 88 years old.
Oh, so you're very older.
Well, but how when you're 89 years old, you can't spend 6 months of rehab.
Right.
How about 3 weeks? Now, if you're 20 years old and it takes you 2 months to rehab, you got the time. Right. I got 85 years old. They want to go on a cruise. They want to go on a cruise next week.
It's very painful, though, right? I mean,
what?
Like getting your toe amputated.
No, it doesn't hurt at all. No.
My dad's after.
That's different.
After
No. That's your dad was a different story.
Yeah.
No.
All right.
No. I mean, you give anesthesia. No.
I'm going off of just the one thing that I know.
No. It's not. If it's done right and appropriate, even bunion surgery, I've done cases where. People don't even need any pain meds. We after the surgery we put anesthesia in there, which lasts for about 6 to 8 hours. We don't even do it. It's like a local block, and sometimes we put a little steroid in there. People do great. I mean, I have a lot of patients that take no pain meds whatsoever. Maybe some Tylenol, maybe 1 Percocet, maybe 2. Huh. Okay, so a lot of times, sometimes procedures hurt. Where you have run into is trauma. When you have a trauma patient, there's a lot of soft tissue injury. See. But when you operate, we do something. I do anatomic dissection. So I've trained to go in again. Remember the stealth bombing? I make an incision. We go right to where the bone is, where we have to cut. Yeah. We don't cause a lot of soft tissue damage or dissection. I've assisted, or trained doctors. I mean, they're butchers. I mean, like they're all over the place. They're pushing on the tissue, abusing it. Well, then you're going to have pain, or you hit a nerve. You got to be careful. You got to move structures. You got to know in your mind.
The difference between.
You got to know the anatomy.
You need to have skilled hands working
on
you.
Yes. I mean, how I dissect, I don't use a scalpel. I use a scalpel for the initial incision. I use other instruments to move the tissue away.
Right.
Okay. And I use what's called a. Basically, it's a pair of scissors. They don't cut they don't puncture, okay? Right. And they're like a medicine bomb. So there's technique that you could use and learn. I trained with a lot of plastic surgeons in my early days, so I learned how to be very gentle with tissue.
Technique's a good word.
Technique is very, very good.
Yeah.
And you have to be careful what you do. So my point is about pain, and you have to know how to manage it. You don't want to cause a lot of trauma. You want to get in and out of there, and all of these things contribute to a good outcome. I've seen people who have had horrible ankle fractures, injuries to the lower leg, and they've been in the operating room for like 10 hours. Wow. That's not good. I mean, and sometimes you have to be, but the soft tissue envelope, that the skin and the tissue got injured, and those people could have chronic pain. That's worse than anything else. So anyway, the bunion procedures are out there. I look at the Facebook. There's all kinds of controversy, which ones to do, this, that. I think that
it's all over YouTube too. That's all I see is stuff about bunions.
Right.
And the other thing, it's everywhere.
Right. Yeah. I want to make another point too. Do you need to have bunion surgery because you have a bunion? Well, in my
see, that's the cool thing about you guys. You specialists, you know when to cut and when not to, and it's very important to know when not to.
Well, here's the thing: if you have no pain, say you come in, you're 40 years old, and you had flip flops on, and you're at a beach or somebody says, hey, you got bunions, maybe you should have that taken care of because if you don't, you're going to be crippled in 10 years.
Right.
You come to me, I would say this. I would say, listen, we could watch it. You have no pain now. You're 45. I don't have a crystal ball. I don't know if it's going to get worse. I could ask you, does your mother and father have bunions? Does your brother and sister have bunions? Maybe it will get worse. But we could watch it. You come back every 6 months, we'll take x-rays. But for somebody to say, oh, we got to operate on this because it's going to get worse, then again, have them put that in paper and say, I guarantee it's going to get worse. I want to see that. I want to see that.
So family history plays a part?
Well, you would listen, if your dad died of a heart attack, your granddad at 40 years old, and your granddad died of a heart attack at 40 years old, and your mom died at 40 years old of a heart attack.
Yeah.
And
it might be in my cards, yeah.
Yeah, it might be in your cards. So family history is always very important.
Yeah.
So I always look at that, but I'm trying to, you're asking me, will this get worse? Based on, should I have surgery done if I have no pain? Again, I'm saying no. So somebody come to me, I say, first thing you do is modify your shoe gear. Most people have bunion pain because they're shoving 10 pounds of potatoes in a 5-pound bag.
Now, would orthotics work in this situation?
Sometimes they will. It depends on what kind of bunion. Yeah. But you could try it. It's a great try. Most insurances cover it.
And
so
you do it in office,
yeah,
right?
Yeah,
you mold it to the person's foot.
Yeah. What I do is somebody comes in. First thing we do is we take X-rays and see what it looks like and what's going on and get a good history. Have you had surgery on this before? Was there trauma? All of that. And that makes a big difference where we go. Right. Next thing we do is we talk about, so we get a diagnosis, we get a prognosis, and we get a treatment options. And usually what I recommend is cortisone injection, anti-inflammatory, shoe modification, wider shoe, bigger toe box, stuff like that.
Right.
And injection, anti-inflammatories, orthotics. That knocks out a lot of people. They do very well with that, and they're good. Now, after that, and they still have a lot of pain, and then you could start talking about surgery, but only after they fail conservative therapy would I even talk about that. Now, so if they continue to have pain after all of that, say 6 months, whatever, and they can't work, they can't play, do their bowling, they can't go shopping, right. They have a life-altering situation, then sometimes we get, we got plain view x-ray, sometimes we get an MRI, sometimes not, and then we talk about surgery, and we talk about what's the best thing for them, and ask them, here's your options, I give the patient an option list, almost like a la carte menu. You could have a closing base wedge, right. You could have this, you could have that, and you get to pick and ask me, okay, what do you think about this or that? And then if you have any doubts, like a lot of times I'll say, listen, go get a second opinion, Sure. And then if, say, there's a procedure, I'll tell you another thing how I am. Where I say it's my way or the highway, if I go down, I say, listen, that procedure you're picking is really not indicated for you. It's not necessary. But you say, well, I saw it on the internet and I want it. Then I would say, listen, I think what you should do then, I would say, if I feel that way about it, I will say just, then you go find a doctor who will do it.
That's the thing. A lot of this is floating around everywhere. On YouTube, on Facebook, anywhere you look, and especially if you have problems with your feet, the search engine, the algorithms show you this stuff. But you have to remind yourself, you're not every person that you see. Like if you see a commercial and they're doing a procedure on one particular person, yeah, they may have a similar issue like you do, but you're still different.
Well, it depends on, and also depends on the doctor's philosophy.
Yeah.
So for me, I'm going to let you make a decision, but I'm not going to let you make a decision that I think is so detrimental to you. You follow what I'm saying?
Yeah.
And I will say, listen, I don't feel comfortable, and I'll give you a colleague's name who does these things. Go get an opinion with them. You know what I'm saying?
Yeah.
Or go get another opinion or two opinions, and well, usually what I'll do is I'll back off. Now, there are doctors who don't give a shit. They're like, listen, they got a bunion, they want that procedure done. Maybe it's not the one that I think is best for them, but I'll do it because they want it.
Right.
And they're appeasing the patient, which I understand. And maybe there's an economic incentive, maybe not. I don't know. I think maybe it's more they just want to help the patient, and But there is a line where I will say no. I don't think this is appropriate, right. And I won't do it.
Because I know with Dr. Jasper, we talk about a lot of other like pain doctors,
right.
And they're not as well trained, and they kind of get stuck on a procedure that might be 35 years old, and there's so many better ones today. but they're only doing that for their patients because they don't want to learn any further than they have.
That's a little bit opposite right now. This new procedure is being pushed. And they're saying the opposite, that the other procedures, the closing base wedge, the Austin bunionectomy, the fusion are old 35-year-old procedures, and this is better, newer, better. Yeah. But
for some of them, if they ain't broke, don't fix them.
It's not. That's not the way to look at it. The way to look at it is what's indicated and what procedure is best for that patient. Okay. There is no, in this situation, it's different than what happens with Dr. Jasper. You can't, that's apples and oranges. It's
I dig it. It's different. It's different stuff.
No, there are, listen, this is new, doing like, say, the Lapidus. It's been around for years. The technology is a little bit, the hardware is a little bit better. Right. The technique is a little bit better. Like total knees, now the mechanics are doing total knees. My colleagues could do a total knee in 30 minutes, because of the equipment and everything. So they do have better outcomes, especially if they churn them out. So, but again, it's I hate to go down that road where I just say one procedure fits all, and this is like the panacea. Yeah. Because, doing a Lapidus, it's a lot of surgery. You're fusing a joint, and not every joint fuses. Ask the doctor what. Can you guarantee me 100% that joint will fuse, and it will fuse in the right position, and I won't get elevation and all that? And can it happen with the other procedures? Yes, but it's less likely in certain procedures. Right. And if you don't need that procedure, why risk it? If you do need it, then you'd get it done because you take the risk. Because I can't, you follow how it has to fly.
Yeah.
Bunion surgery is a unique thing. Now, there is a lot of physical therapy you could do. There's a lot of, like shoe modification. So I would always exhaust conservative therapy before I operate on somebody.
And this is all catered to this, the individual patient, the specific issue that's going on with their foot.
Right. I had a lady come in. I remember a couple years ago. She had 2 bunion procedures done, and they one done 30 years ago, another one done 20 maybe. 10 years ago.
By other people.
Yeah. But and so now she's got an arthritic joint. It's all crooked and everything. And right there, the fusion, the fusion at the big toe joint, that's perfect for her, You put a couple screws in there, plates, whatever, and she's, and it gets rid of the pain, it corrects it. Right. And if that thing fuses, most likely she'll never need another procedure again. I don't care what bunion procedure you have, like the Lapidus or the Austin or the closing base wedge. That's not guaranteed 30, 40 years down the road, you'll need another procedure. Okay, but you know what? If you're 40 years old and you have a total knee, how long does that knee last?
Right.
I mean, none of this stuff is 100% either. Yeah. And that's why I say be very careful, what you want and how bad you have to have it. I got people who come in for an ankle sprain or a fracture or an infection, and they got a mild bunion. I go, does that bother you? They go, no. I had a lady in yesterday, a day before. She has a hard, big bunion. She has no pain in it, none whatsoever. I think she had an ingrown toenail. I says, that bunion hurt you? She goes, it was on the other foot. So what, you know what I'm saying?
Yeah.
But then I had another lady come in who, she got these really bad lesions on the top of her foot and the bottom of her foot because she's got such a bad bunion. It's all arthritic. And she never did anything about it. So now she's got, complaints. I put her in orthotic. But she can't have surgery. She had a abdominal surgery. She's very high risk. You can't touch her. But so that's what you got going on there.
Yeah.
So everybody's different. But I'm just getting a little bit concerned that the media and the internet is putting out this information that people need to have a little bit more perspective on bunion surgery and somebody who has 40 years of experience.
Right.
I mean,
well, that's the thing. You find a good doctor like you got to trust that doctor and the path he's going to take you down. Especially these fellowship trained and board certified physicians. These are the guys you stick with. You don't have to look around. You don't,
Well, you want to find somebody who has, you want to have somebody who has the training. That's the bottom line.
Yeah.
I mean, it's not rocket scientists, but I tell you, people are lazy. People amazing to me how lazy they are. that they don't, I went to him, and he's in my insurance or her, and then I was referred by somebody else, and, and then, which is fine. But, if they, I don't see why you can't get another opinion. I don't have no problems. You come to see me and you want another opinion. I love that. I'm like, go get another opinion. Go talk to whoever you want to talk to. And I think that's good. And then you come back and we could discuss what they recommended. How about that?
Right.
I could defend what I recommend to have done or what I'm recommending. And your doctor should be able to do that too and defend it. And then you make a decision. That's just the way life is, Yeah. I'm trying to show you a picture here of a closing base wedge. Let me just see here. But it's all what you want. And now these are not showing here. So, there's the cut right here. Okay, so go back to my thing. I want to show. So this is a closing base wedge. See where it is? See a little piece of bone. Yeah. So that's a closing base wedge osteotomy, and I just put one pin through there. That's a picture of it. It's a diagrammatic picture.
So you cut through the bone.
Take a little wedge out, and then
you
goes
take a
over.
Little wedge out, and then you just move it down.
Yes.
Oh, that's okay. Yeah.
See how simple?
Yeah.
Now the
simple.
the lapidus, you go down to the joint there, and you fuse that. You take the joint out, which is this is a lot simpler in my opinion, but it doesn't correct in 3 planes. But if your deformity is mostly in 1 plane, what difference does it make?
Yeah. What kind of? I mean, you are losing length on your.
Yes, you are.
Yeah.
Well, you got to be careful. You got to be careful how you do that, and you got to make the cut in a special position so you don't lose too much length. But the lapidus, you lose length too. Yeah. So in the Austin, you lose length too. But let me just see here. So I fixated. So here's a picture right here. There's the cut. Oh, sorry.
Sorry.
Let me go here. Here it is. This is a good picture right here. So there it is right there. See, there's the bunion. You cut it, right? Take a wedge out and you put a screw there. I put a pin. That's a great procedure. I've done thousands of those over the years. I really have. And I think it's it's a really, really good procedure.
Yeah, there's another wedge right here in this drawn picture.
Yeah, I've done that. And just trying to show you. So, you go back to me, Jeremy.
Sure thing.
I think that people should spend some time going, hang on, Jeremy. I think people should spend some time going on the internet and looking at these things. It's not that hard. There's a lot of literature out there. And like I said, every year, every so many years, they come out with the best procedure.
Right.
So back in the day, the Austin bunionectomies in the 90s, that was the premier best surgery. The lapidus was still around, the fusion. It was nothing new. I used to do a procedure called the Keller bunionectomy, right, where you take this piece of bone out. It was around for millions of years. I tell you how it was. And again, you talk about old technology. And I'm not recommending that we do this today, but back in the day, if you were 60 years old, you had one bunion. If you were under 60, you had one procedure done. If you were over 60, you had another. I remember, this is how old I am. I remember if, you did different surgeries if you were a man or a woman. Because she's not gonna, she's not the breadwinner, I mean, medicine there's a lot of ways to pick what the patient is. Today, it should not have anything to do with. Sorry, Gabe.
That wasn't a sexist thing, was it? Or?
Yeah, it was.
Absolutely.
Yeah. But also it was age. It was an age thing. If you're over 60, you could, you're not going to be doing a lot. Now it's a whole different story. I'm just giving you a perspective of how
of the past and
right.
Today,
and today, what's different too is that we have a lot of technology. We have screws and plates and axillary things that could help us to do the work. But is it really anything better, or is it just a rehash of the same old?
Right.
Like I'm saying, a lapidus procedure has been done for years and years and years, and I was trained in it back in the 80s. So it's nothing new. And same thing, closing base wedge, Austin bunionectomy. Goes on and on. Big thing back in the 90s was implants, putting implants in a joint, these celastic implants or metal implants. They kind of fell, they're not that big anymore. They had a lot of issues. So, now these procedures that are being done, you got to give it some few years to see how they play out and how many complications and how you deal with the complications and those and the long-term outcomes. if you're doing a Lapidus now, and it say in the past 10 years, 5 years, 6 years, that it's really become very popular, well, it's going to take 20 years. How do you know you're going to not get a recurrence in 20, 30 years?
Right.
Well, we're not there yet. You gotta wait.
Yeah.
I know that closing base wedges, which have been around 20, 30, 40 years, you don't get a lot of recurrences, because we've had that time. So how do you know now? Well, you can't, unless you got a machine to go ahead 20 years. You can't tell me this, there's that much literature out there,
right.
and not with a big volume of people. So in a sense, we'll have to revisit this 20 years from now.
Well, we'll be here.
We'll be here. I hope so. Yeah. So anyway, that's about it. Anything else you want to just close with, Jeremy? Like, what's going on? Oh, I tell you what. How about we do this? Just give me 1 second, and I wanted to talk about something here. Let me just see. So you let me go here. Just website design. Let me find something. There was one article here that I wanted to talk about. Let me see if I can find it here. This is interesting here. So we just a little politics now, and we'll finish up. How much time we have? We got we'll give it like 10 minutes, okay. 10 minutes. So there, we're talking about all this. We're talking about all of the immigration in this country, and people are like going crazy over it.
Right.
But one of the things from a medicine standpoint has happened is that in the past 4 years, there's been an increase in tuberculosis in the United States, tuberculosis cases in the United States. Okay. Right. It's about a 36% increase. Now, just so you know, tuberculosis is a disease. It's a bacterium that it spreads could be through milk, but also coughing, air. Gets in your lung, you get in your bones.
Through milk? Yeah,
it could be. You could get it through. That's why you pasteurize milk. But tuberculosis is a bacteria organism, and it could kill you. And there was a big outbreak about 2 months ago in Kansas. Like 67 people had acute.
We talked about that.
Yeah.
We talked about that.
So and in New York City, I think about 90% of the cases are on these immigrants. I don't know if they're legal or illegal, but this is you have all these people coming in the country. Were they vetted? Were they checked for tuberculosis?
Were they checked for anything?
Anything. Now,
it could be a wide spectrum of things that are being brought in. Yeah.
In the United States, we do not get a vaccine for tuberculosis. Okay, understand that?
Right.
So we're wide open to a tuberculosis infection. We have no immunity to it. We have no vaccine. Other countries do, but the vaccine is it's not controversial, but it's got some side effects.
Sure.
So what the United States decided is that we're going to test people who are like doctors and nurses, whoever's exposed to a lot of patients. You'll get tested every year for tuberculosis. They do a little needle in your arm, and they see if you get a reaction. Right. It's called the Times test, okay? So now you have all of these tuberculosis cases. Well, this broadcast is coming from New Jersey, right? So go to the video, as they say. Go to the video. So here it is right here. So this is, what's the date here? This just came out a couple days ago. New Jersey student diagnosed with tuberculosis. Contact tracing underway. Okay, Let's go to full story. So this is hitting home, Jeremy.
Yeah.
This is right here in New Jersey. So this was 3 days ago. How does that? A Kelowna high school student was tested positive for tuberculosis, is responding well to treatment. The school district announced late week was notified. So the treatment is like 6 months of...
Wait. Is that Kelowna High School?
Yeah, Kelowna High School, yeah.
This is up north?
Yeah, New Jersey. Yeah, it just happened, yeah.
Oh, geez, that was like down the block from where I lived.
Yeah, well, So
I live right on the border of Islin and Kelowna.
So tuberculosis is caused by a bacteria resulting in an infection that typically affects the lungs, and the infection and disease can be cured with medication, but a lot of medication. So now the school district is looking to go talk about all these people who could have got infected because it's contagious.
Wow.
And according to the information from the American Pulmonary Association, it is not easy to contract an infection of tuberculosis unless usually a person must have close contact with the infected person for a substantial length of time to contact the illness. Casual and limited contact with a person with active tuberculosis is not enough to someone to pass the infection to others. So I don't know how, I have to...
Wait, go back up again.
Right.
It says it's very important that potentially exposed individuals participate in this tuberculosis investigation. Yeah, that's it. You guys can't be hiding. You gotta be out and get tested because.
Right, but here's the thing too. This is kind of misleading. It says, it's not easy to contact infection, tuberculosis. Well, this kid did, number one. But number two, think about this, Jeremy. You're a diabetic. You could be immunocompromised. You had a transplant. A lot of people who are young or even older,
you're more susceptible to catching something like this.
Absolutely,
because of that. Yeah,
absolutely. And I don't know how contagious it is. I could tell you, I'd have to do some research, but I don't know the American Pulmonary Association. I could tell you right now, there was an outbreak in Kansas, 67 people, acute. Okay. What about if you're a heroin addict or a drug addict or you're chemotherapy? You're a young kid, with getting therapy. You're rheumatoid arthritic. You're 20 years old and you're taking an immune compromising drug. You got really bad psoriasis and you're taking one of these immunocompromising drugs to help you with the psoriasis or eczema or whatever. Yeah. You're more susceptible. You go watch the TV commercials. They'll say, this is a great drug, but you got to be, be careful. It could make tuberculosis worse. So again, thank you for the 81 million people who voted for Biden and open borders.
Yeah.
Okay, and all these people that came into this country. Okay, this is now your kids are exposed to tuberculosis, and you are too. So go get tested, like you said. Kumbaya, but I just want to throw it out at you. Now it's in New Jersey. Kansas City, then they also identified in Kansas City 1,700 people who were chronic carriers. So you could be a chronic carrier and have no symptoms either, right. Okay? And again, yes, it could be passed, I think, by milk, other ways, ingesting, it goes into your bones. So it's more complicated. We could get into it, but a lot of people die from tuberculosis. It used to be not uncommon in the United States. Tuberculosis, yellow fever,
most famous
diphtheria.
Person who died of it was Doc Holliday.
Well, I don't know if he was that famous, but yeah.
Well,
no,
well, infamous. How about that?
But that's that's an interesting thing, Jeremy. And let me get you one more. So I thought that was a very, you talk about politics. We try to stay. I know you don't want to hear that.
I don't know what I want to hear.
So now here's another thing. Again, in medicine, let's go to the video. Yeah. I just have a whole bunch here. We're going to bang through real quick. So nearly a third of cannabis samples from New Jersey dispensaries tested positive for mole. Consumer group says mole. Mold in your, I guess maybe you get high.
Mold?
Mold.
In the cannabis?
In the cannabis.
That ain't good.
That ain't good. Let's look at the story here.
You're not supposed to be breathing that stuff in, and you're puff passing.
Well, I just want to say this was by Michael Doherty 3 days ago, KYW News. I would imagine it's accurate. So now you got mold in your pot. Go back to me. Get out of here. Mold. That's listen. You can't win.
What a drag, man.
What a drag. So I love these. I got it. We get a. Hang on. We get a. What do you call it? So here's a couple. I could keep going on. This is a great one here. So this is an interesting story here. So people rent out their houses, Airbnb and all that. So this is a sad case here. New York couple charged with manslaughter after Cape Cod mother, young daughter die in fire. So they rented out their house. They didn't have fire alarms, I guess. The place burned down and 2 people got killed. So they charged the owners of the house with manslaughter.
Wow.
Manslaughter. Yeah.
Well, you got responsibilities if you're going to be renting out your place.
Well,
man.
you gotta
make sure everything's up to code. And all of that.
Yes. So so I want to see what else here. Students arrested for high school too. So here's another one. Wait, not yet, Jeremy. Hang on, I'll tell you when to go. Right. So this is another one here. Okay, go to me now. Right. This is a tragic case here, and I saw this. So a champion kickboxer, 15, collapses minutes after fight and died in hospital. Family pay heartbreaking tribute. So this is a really sad case here, and what you have to be careful with any contact sport, football, kickboxing, boxing, is getting hit in the head and having a bleed, brain bleed, and so this was tough. I think this was in another country. I forget where it is. It doesn't matter, but you got to be very careful, especially with young children. You know what I'm saying? And he suffered a brain bleed. So I always tell people, with head injuries. And now the United States is really getting on top of it with football, concussions and everything. All the athletic trainers are really jumping on it. Yeah. And, you don't want to see that. It's something that, is preventable. I'm just throwing these things out here.
Sure.
I got one more for you. I think this is ridiculous here. No, hang on. Where is it? Here. So this is in New Mexico. This is a tragic case. And I want to just talk about what happened in New Jersey here in Toms River. But horrifying moments, 3 New Mexico boys decided to run over a physicist biking to work, revealed, just bump him. So they got video. These 3 kids are in a car. They're young.
Just bump them, bruh.
And they hit him and they killed him.
Jesus.
And let me see how old these kids are. So listen. So this is the thing. 3 boys riding a stolen car.
11, 10, and 15.
Now, what do you do with them? Do you put them in the electric chair? Do you give them life in prison? They're 11, 13, and 15. What do you do? Are they responsible? They killed a guy.
Are they showing any remorse?
I don't know, but what are you going to do? Let's say they don't show remorse. Let's say they go, we're what? Then you want to
give a shit. We did.
So what do you do? So what do you do with it? Should you firing squad with the 11-year-old? What do you do? So there's a great movie I want to point out to you. It's called Young Savages.
I think you should lose your license for good. That's it. You're done.
Well, who's going to pay for him if he can't work or anything? Stop for a second. Listen, there's a movie I want you to, before you comment, next time you come back, it's called The Young Savages with Bernd Lancaster. Talks about very similar stuff.
Familiar, yeah.
So anyway, these kids, they had video. They say, just bump them, out for a joyride, and the guy died. So listen to this. So 2 weeks ago, this is New Jersey, Toms River, where we live here.
Yeah.
There was kids in a car. I don't know if the driver was 17 or 14. There was a bunch of kids in the car. They were over in Lavalette in Seaside Heights, which is on the beach. They were driving up the road. They were going in excess of 100 miles an hour. So the cops had to chase them a little bit, but had to stop the chase because in New Jersey, you're not allowed to chase people who are going fast because the theory is you can make it worse. So they backed off and let the kids go. They gave it to the next town. The kids went over the bridge, right, going 118 miles an hour. Jesus. Cops didn't set up anything because they're not allowed. They could have put maybe cars at the bottom of the bridge, stopped them. Yes. Kids kept on going. This is at night. They shut their lights off. The kids shut their lights off. They went down the highway, and they went all the way to Route 37, which is about 3 miles, and the light changed. They blew through a light, and they T-boned a car with 4 kids. 2 kids were killed instantly. They're just having the funerals today or yesterday. And the other 2 are in critical condition at Jersey Shore. I think the 2 girls were twins, sisters. And they had video of the kids in the car, being idiots. Doesn't sound like they're remorseful. So what do you do with that? What do you do with them, Jeremy? What do you do with those kids? Again, these are terrible. But when babies kill baby killers, these are baby killers, 11, 12, 13, 14. What do you do with them? What do you do with them?
Picture this, Mike, okay?
Tell me what you should do with them.
So if they made the movie Smokey and the Bandit today, there'd be nobody chasing the bandit. That's mental.
Well, listen, there's a lot of things to unload here. I don't want to get into a whole big rabbit hole, but first of all, watch the movie.
What do you do to those kids?
Okay,
though?
So watch the movie. Watch the movie called Young Savages.
What would you do? Tell me that.
I think personally. Do we have anything? I think I think that there is a possibility. If there is a possibility of somebody who's young to be rehabilitated, I would not, give him the death penalty. Stop. There's a kid, 14-year-old kid, shot a cop in Newark 3 weeks ago, killed him. 14-year-old kid.
Well, Trump's saying now, you shoot a cop, you'd get a death sentence.
Okay. Are you going to take a 14-year-old and execute him? That's 14 years old. Now, can a 14-year-old make a mistake? Can a 14-year-old be rehabilitated? Those are things that you have to think about.
A 14-year-old can father a child. A 14-year-old can pick up that gun and decide to shoot that cop.
Well, so 12-year-old, 11-year-old could do. What if again, these kids who drove the car, say it's an 11-year-old kid, what do you do? My point is, what you're asking me, it's a tough one. First of all, the kid who shot the cop, he has to be put away for a long, long time.
Yeah.
Maybe, I don't know how long. He needs therapy. I don't know what the situation is. I think it's if you read the book or watch the movie, Young Savages. 3 kids killed a blind kid. He was supposed to be an innocent blind kid. It turned out not to be so innocent. But the 3 kids all had, different reasons for what they did. Okay, and so was this say the 11-year-old, was he mentally, was he brought on by the other kids? Were they intoxicated? I mean, there's a lot of things. There's no easy answer.
I get it.
But they killed these
kills. I
watched
a film once where it was, these three or four guys, and there was a developmentally challenged girl in the building, and they snuck her away to I guess one of the rooms that wasn't being rented.
Right.
And they raped and murdered her.
Right.
And that was like this. Like, what do you do? And these kids are trying to hide it. The fathers are trying to hide everything and blow everything over. But this the point about this is this stuff happens all the time. These kids are doing crazy stuff. That's why it's important for parents to be parents again.
Right.
You can't. No. It's too young. If a 14-year-old is walking around with a gun and the parents don't know what they're doing or up to, that's a problem too.
Yeah. Well, you need justice first of all.
You need justice. Yes. After the fact, you need justice.
You need deterrence.
Before the fact,
you need deterrence.
You need discipline
and deterrence.
Yeah.
So the. But you're going to put the kid in. I'm being facetious, but put him in an electric chair and pull the handle on him.
Yeah,
it's a very difficult scenario. It's just so funny, not funny. I shouldn't say that, but tragic that in the past there's 3 cases. Strange.
Yeah.
3 cases now, very young children, and the movie Young Savages, who profiled this exact issue, was did in the 60s. So nothing's changed.
Yeah,
nothing's changed. It's the same shit. We're dealing with young kids who are killing people, and. And they seem to be doing it recklessly and purposely.
I think that was actually an episode of NYPD Blue I was talking about.
Oh, yeah. Well, I think that these people, you can't let them go back to society for a long time.
Right.
I'm not a real good fan of the death penalty. And the only, but I think that life in prison is certainly reasonable.
You got to imagine though, if you've raised your child to be 14 and old enough to shoot and kill a cop, that child needs rehabilitation. He needs to be taught a different way of living to be released out into the public again.
And they may never.
And they may never. Yeah, you're right.
I was when I was doing my training in Philadelphia. Yeah. I was at the. I don't know where hospital I was at. I think I was at Jeffrey Medical Center, but and they had a jail wing there, and this girl, she threw her 2 kids off a bridge, and they drowned. They died.
How old were the kids?
I don't know. I don't remember. Young.
Must have been young enough, right?
Yeah. No, they were tiny. Whatever. Yeah, it was tiny. Cold. It was February. They died. And but they brought her in. She supposedly fell down the stairs or something. Cops beat the shit out of her, But I was dealing with her. I remember talking to her. Again, this is, a million years ago.
Oh, so you were talking with her?
Yeah. She was in the hospital that I was training at that time. I was doing anesthesia. But I remember there was nothing there. She was, I don't want to say.
And they beat the shit out of her?
Well, I don't know what happened. They probably got pissed. Who knows? Back in those days.
Sure,
I mean, she wasn't dead or anything.
You killed.
She was knuckled up. But
I get you.
But my point is that they probably got so pissed they have kids themselves. But my point is, when I spoke to her, I realized that there was nothing there. She was, devoid of any
dead inside.
Not even. Yeah, just I don't want to say mentally ill, but we used to use the word retarded. It's probably not appropriate nowadays, but there was nothing. She
had no conscience.
Where she grew up in the ghetto. I mean, it was sad. I mean, she was a victim of poverty.
Victim of circumstance.
Yeah, I mean, really, and I wasn't mad at her, it was sad because, she was just no training, no. I don't think there was any parents. It was very sad. It was very sad, and. Who knows? She probably was desperate. She couldn't handle it. I don't know. We have to be compassionate to a certain degree, but she killed 2 children. So can you let somebody like that out? And you know,
I mean, she could have been like a sociopath and not have no emotions.
But some people are mentally ill. Some people
Yeah.
are you know, they see things, they hear things. My point is that there's always there's a lot of different things. Right.
Yeah,
and you know, just to take her out and put her in front of a firing squad because she killed 2 kids may not be the most humane. She was traumatized herself. Who knows what happened to her? I'm just telling you, I've seen enough where people who do horrible things have had are not functioning on a good level. And I'm not say it's right, but it's, you know, what do you do with these people? What if you know, what do you do? So, you know, you're back to the square one. So now you had the Tom's River one, the kid, you know, and they supposedly have video them, you know, being boisterous and, you know, oh, let's do this, let's shut the lights off. You got the kid up in Newark killed a cop. I don't know what, you know, I mean, then you got the, you know, the in New Mexico, 11, 12, 15 years old, they ran over a guy going to work. What if that's your father? What if that was you? You know, and then, you know, what do you want to have done? You know, I mean, it's a tough one. It's a tough one. You understand?
When I was a kid, there was some boys. We had a busy street, Middlesex Avenue. Okay, right. And this is right. This is right on the border of Island and Colonia. Okay,
right. I'm listening.
And these kids were hiding in a bush, waiting for a car to come by, and they had a frozen turkey.
Right.
Okay.
I know where you're going with this.
Yeah.
I heard
and
about this.
as soon as the car was zipping by, they lobbed that giant frozen turkey out at the car. Right. It went like with the speed of the car was going, and that thing is like a cannonball. Okay. Yeah. It went right through the windshield, killed these 2 old couples, and these kids are like, what did you think was going to happen? Yeah,
they didn't think. They
didn't think. Yeah.
So, you know, again, we could spin around and around and around.
Sure.
I recommend everybody watch that movie, Young Savages.
Yeah.
Jeremy, let's. So listen, we're on YouTube. Please like and subscribe.
Yeah, please like and subscribe.
Go through all our.
To make an appointment with Dr. Kachmar, go to call 732-269-1133. That's 732-269-1133. For more information about Dr. Michael Kachmar and all the wonderful things we talk about on our show, go to JerseyShoreFootAndLegCenter.com.
Right, and you don't have to do anything here, Jimmy. And then scrubbing up with Dr. Kachmar every week. And listen, thank you everyone for tuning in. We'll see you next week, and have a nice day. Take care. Bye-bye. Jeremy, send us out of here.
All right.